This is EHJ Today, and I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal at the Cardiology Update in Davos, Switzerland. And I'm talking to Felix Tanner, who is Associate Editor in our journal and Director of the Echocardiography Laboratory at the University Heart Center in Zurich. Welcome, Felix. So non-compaction is our topic of today. Why non-compaction? What does it mean?
Non-compaction is cardiomyopathy. It is a non-classified cardiomyopathy. And in these patients you have a peculiar phenotype which manifests itself by a reduced thickness of the compacted myocardial layer you usually have. And this you usually find in the apical segments or in the midventricular inferolateral segments.
Of the left ventricle, huh?
Left ventricle.
And how common is it? Is it a rare disease?
There are not too many data regarding its incidence, but you can assume that the incidence is 1 in 1,000 patients.
And is it a hereditary disease? Is it familial?
It is a familial disease in some patients, but we also see sporadic cases which are not familial. And there is no, but you know, when you look at the genetics, you do not find any specific mutation in the genome.
So several mutations could cause
you
disease.
Find different mutations which you also encounter in different cardiomyopathies such as hypertrophic or dilated phenotypes. So this is not comparable to what we see with ARVC, right, where all the mutations are focused around the desmosomes.
Yeah. So there must be post-transcriptional modification of gene products that lead to either one or the other cardiomyopathy. But this has not been fully understood.
Not quite. You also see mixed phenotypes, where you have hypertrophic traits mixed with non-compaction traits.
So as a general cardiologist, what symptoms do these patients have? When do I have to consider this?
Most patients present with dyspnea on exertion or heart failure. You also have patients presenting with non-sustained or sustained ventricular arrhythmias. And you have patients presenting with cerebrovascular embolic events or peripheral embolic events.
So this cardiomyopathy leads to left ventricular dysfunction, heart failure, thrombi in this non-compacted myocardium, and arrhythmias.
Yeah, you do have left ventricular dysfunction in most of them. What is interesting is that the degree or the extent of ventricular dysfunction does not correlate with the number or the distribution of involved segments, which is quite confusing. And the ventricular arrhythmias are consistent with patchy fibrosis you see histologically when you examine these hearts. And the peripheral embolic events are explained by by the thickened non-compacted layer you see. You have the compacted layer is thinned and the non-compacted layer is thicker than usual. So you have prominent trabeculations in the apex, forming deep recesses in between the trabeculations. And in these recesses you have low flow conditions.
And so thrombi form, right. So then if you take the patient, as most patients in the cardiac outpatient clinic, to the echo lab, how do you diagnose non-compaction? What are the criteria?
There are different sets of criteria by 3 different working groups. Mm-hmm. And unfortunately these criteria differ.
So we need a consensus conference, yeah?
That would be great. Yeah. So at our center we are keen enough to apply our own criteria which we developed over the years.
And these were, what do they
so
say?
These criteria, it's a set of criteria you have to apply. So first of all, Also, when you diagnose it by echocardiography, you generate an apical short axis view, because we made the observation that with this view you are perpendicular to the pathology and you can best appreciate its extent. And you choose an end-systolic frame which lets you measure the thickness, the relative and absolute thickness of the compacted and the non-compacted layer in apical short axis view. Right. And the criteria, the main criterion is that the thickness of the non-compacted layer is at least double that the compacted layer. Then you also should take care to analyze the affected segments. So typically it's in the apical segments and in the midventricular invololateral region. In addition, you should analyze whether these recesses are perfused from the ventricular lumen to rule out coronary artery fistulas, which might
and they're not
confound
perfused,
that.
but these are perfused. And so you get a Doppler signal.
And that's that, more or less.
So let's assume you have the diagnosis. What do you do with these patients? Do you anticoagulate them? Do you give them a defibrillator? Or what do you do?
That depends on the clinical presentation. If the patient presents with heart failure, you establish state-of-the-art heart failure therapy, similar to dilated cardiomyopathy. Right. That's just the same.
Yeah, with drugs like ACE inhibitors and beta blockers and so on. Yeah.
Now, at our center, we do not anticoagulate these patients unless they present with embolic events. And if that's the case, we use conventional anticoagulation. None of the new...
It's vitamin K antagonists.
Yes, yeah, none of the new anticoagulants, because there is simply no data in this patient population.
Right. And let's assume he has ventricular tachycardia. What's the risk of sudden death? Is this substantial in this patient population?
It is substantial, in particular when the patients present with sustained arrhythmias. Yeah. And these patients should be treated by an ICD.
Yes. So what's the outcome? I mean, you studied quite a large series, considering that this is a rare disease. What's the 5-year survival rate of these patients, roughly?
It's tough to say, because all the published series are quite small.
Yes, in the hundreds, huh?
In below the hundreds.
Below the hundreds.
Yeah, there is not a single series looking at outcome in these patients with more than 100 patients.
But we had patients that I treated myself that ended up in end-stage heart failure and had to be transplanted even. So it can really progress severely, can it?
It can, yeah. And we have some patients which had to be transplanted. Yes. That's correct.
Right, right. So what's the next step in the research in this rare but interesting form of cardiomyopathy?
See, there is the main problem at the moment is some diagnostic uncertainty in many patients.
Yes, it's not a trivial diagnosis. Yeah.
It's a difficult diagnosis, in particular in dilated ventricles, which is often the case.
Yes.
And the other problem...
And these sinuses are less obvious if they're really dilated.
The sinuses, the recesses are less obvious, that's correct. And it is more difficult to generate a perpendicular short axis view. So the risk that you generate oblique views is bigger.
Yes.
Because the ventricle is more spherical.
Yes.
So that makes diagnosis more difficult.
Right.
So it is important to refine the current criteria.
So you need a consensus conference.
We are working in this direction, yeah.
All right. Thank you very much indeed.
You're welcome.